As we gather for this special event, we humbly seek your divine providence to help us share your grace to others. Help us engage in meaningful discussions by giving us wisdom, understanding, and guidance. Help us learn and grow and love one another so that we can become better children of yours. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas. May alay ng puso pag-ibig ang alay ng puso ay sa lahat ng bansa namin. At
Please be seated. For our opening remarks, we would like to welcome the Executive Director of the Philippine Heart Center, Dr. Joel M. Abanilla. Let us all give him a warm round of applause.
Morning. I see a lot of penguins this morning. You're now all in your white uniforms. Uh, I was waiting for your invitation last week so that I will have an idea of what the theme is and what to say about. No? Unfortunately, it came a little bit late, and I have to leave for the Department of Health 2-day brainstorming on how to revise and update our medical assistance for indigent patient. So you know how it is to revise a guideline. We take it line by line, word per word, period per comma. No? It's scrutinized by about 100 people represented by COA, by PhilHealth, by PCSO, by DSWD, by the ITC, by DOH itself, and all the directors of various hospitals. So can you imagine how violent it was? But anyway, the main guiding line there is that how to make this assistance to extend them to the needy or sa mga mahirap, more user-friendly, madali. Kasi kawawa naman mga ito, no? Napabalibol sila. Pupunta doon sa PCSO, kuha ng papeles, punta sa DOH, kuha ng papeles, kung saan sila pumupunta. Baka hindi alam kung saan pumunta eh. And tomorrow I leave again because we are again discussing the HPEP or the Hospital Facility Enhancement Program. That is, we talk about equipments and infrastructure and what the hospital will need according to priority. Here, they make a review of the checklist of what or how much was given to a hospital, how much was already allocated, how much dispersed, bakit hindi pa nagalaw ang pera. All of that are scrutinized, no? And it is flashed in front of the entire DOH. That's why I'm telling our admin, please do well, no? Kasi ang kapalpakan mo is made known to the entire country, no? Bakit na iba first quarter pa lang fully allocated na, disbursed na. Sa atin, malapit na end of the year, 3/4 of it is not yet even allocated. Well, there are many reasons. It's not as simple as that. No? May mga bidding, may mga maximum price ceiling to follow, failed bids, and etc., etc. But anyway, that is not your problem. It is my problem. No? But rest assured, we are getting the budget that we have. And I have heard from the executive director of Senator Bongo, we might have an additional funding, hopefully significant enough to cover some of our expenses again. So now going back to vascular, during our time, not much talk about the vascular was being made. Ang naalala ko lang noon, the only one involved in this was Dr. Floremon Garcia. And then, of course, later on, of course, our very able and dynamic Doctora Apola came into the scene. No? And she pursued it with passion until she even passed the accreditation or the diplomate exam of the American Vascular System, the only one. Still? Meron na iba? Ilan? Tatlo. So, ganyan pala kahirap yan siguro, no? Anyway, so even St. Luke's changed its name. It used to be St. Luke's uh, Heart Institute. Later on, they modified it into St. Luke's Heart Institute and Vascular Hospital. So giving impetus to this subspecialty. Well, it's understandable, no? Uh, what the pump, what the heart pumps goes through all these vessels that when diseased, of course, brings about an interrelated problem. So how it is detected earlier on and addressed can significantly change the course of that patient with vascular disease. And we are so fortunate that there are experts now looking at this subspecialty, and we get to detect the problem at its earliest stage. I know marami pang development that will follow. Now, during our time also, when echo was at its earliest, we only look at the heart. In fact, naabutan ko pa na blind procedure pa to get the peak flow across the valves. Doon lang sa flow and the gradient across the aortic valve, sometimes will take us 1 to 2 hours. Kasi blind siya until you are satisfied that is the peak gradient and flow, then we stop. Otherwise, we continue doing it. So when the color Doppler came, wow, that was a big relief for us because outright we are guided where the flow is, where it is directed, where to put the sample volume. So made a lot easier. And then the vascular assessment na ngayon, the flow across the carotids came about and the various parts of the body. So in an echo also advanced, no, that we can have a better visualization of the aortic root. So patients with chest pain, walang clear-cut etiology, we probe into acute coronary syndrome, mukhang wala. So sometimes doon pa lang we can see, baka may dissection at the root of the aorta. May aneurysm that is started to rupture or beginning to dissect. So things are much more efficient now, and I know there will be more to come. So even in the medical armamentarium, dami na rin. No? Dati, ano lang, nang una is dipyridamole, but then studies showed that it is not as good. And then we have the resurgence of aspirin, and then clopidogrel, and then enoxaparin, Arixtra, and Denovax, and everything else followed. So we have the evolution of antithrombotic agents, which is there for you to make use of. Mas marami na kayong choices, mas maganda na yung results. Okay, so even international accreditation committees are aware of this, such that when ACI came about 3 to 5 years ago, they were looking at the algorithm in every nurse station. Okay? And they found out na medyo wanting tayo dyan, and they called our attention. It was not enough naman to not award us the diamond, but then they were able to call our attention, and true and good enough naman our vascular system responded, and in fact even improve it further. So in every chart, I think in every nurse station, andyan yung algorithm na yan. So now, I don't know, smoking is still there, no? But it seems that I'm not hearing a lot of burgers, or baka hindi na umaabot sa amin. Marami pa rin. No, we are, because we're clamping down also on the smoking, the vigorous campaign against smoking. And then we have the sin tax bill, no? Sobrang mahal. And I've heard itaas pa daw lalo. Kasi despite na tumaas na ang presyo ng sigarilyo at saka alcohol, hindi pa rin mapigil, no? Ang bisyo. Talaga sabi nila daw, yung pwede pa daw mapigil yung baha, pero hindi yung sa Bisaya, biga, no? Yung hindi mapigil yung what do you call them, what they call bisyo, no? Because there is some degree already of addiction. There are some dopaminergic receptors already that are involved that makes you crave. I think that is the biggest battle, how to cut that disease process, no? Or that pathophysiology for people to stop. Eh kahit sa drug addiction, hindi may tokhang na nga eh. Pinapatay na rin eh. Andyan pa rin. No? So that is how profound the drug and the dependence to a bad habit. Okay, and so with alcohol, no, alcohol is also an addiction. So now, I don't know if you are requesting also for an equipment wherein there will be simulation, because we are right now looking for funding, because we are putting up a simulation laboratory here once the funding is there. How to simulate insertion of a catheter during core angio, a simulation how to insert the TEE, no, and many others that before testing on a patient, doon muna sa model or sa mannequin. They are relatively expensive, but that will give you confidence and already the feel before going first into the patient. So I think that will be big deal, no? Kasi I can imagine yung takot mo, no, na una-una mong gawin yun. I still remember during way back when our rural, when we were assigned in a barangay health worker, and our group have not rotated yet to OBGYN. And to find out when we were there, we have to assist delivery, which we never did. Ang takot namin baka ang baby mahulog dun sa balde. So and how to handle it properly kasi may technique lahat yan eh. That goes also, lalo na siguro sa cardiac. No? So pati siguro yung mga JCAT insertion or whatever diagnostic procedure na semi-invasive will give you already a gut feel. So this is just a one-day simple. I know some breakthroughs will be ilatag na naman for you to learn. So, and from here, you are open to more developments and changes. So this is very dynamic, and all of this move toward a better approach, better diagnosis, and of course, better treatment, and eventually better outcome for our patients. So good luck. I would like to thank the organizers. No, least I forget them. I saw the name of Dr. Nokum. You're in the organizing committee, right? And Dr. Pai Mateo. So never tire on this. No, we owe it. No, tayo nag-learn tayo sa ating mentors now. It's our time to mentor our young colleagues. And of course, andito naman si Dr. Abola, si Joel Paz, si Chelet, si Tangke is here. Who else ang sa vascular pa? Marami na kayo eh, no? Dr. Ramos, Kevin, o tingnan mo dati, akala ko inuutusan-utusan ka lang nila bumili ng pagkain dun sa Jollibee, vascular specialist ka na pala ngayon. Oo, pasayaw-sayaw lang kayo noon, no? Ah, okay, nakikita ko pa kayo no, nang nagre-review kayo, yung panic stage yun, no? So, but you're done with that. So, well, to the others, as you have decided to become physicians, ako yung kwan ko, byword ko dyan, motto ko, if you decided to become a doctor, for God's sake, please be be a good one. No? Because it is not only a livelihood, you will be the life of your patients, it's at your fingertips. So once again, thank you to the organizers, and hopefully you learn something new or enhance what you have already learned before, so that when you need it, they come handy. No, and that makes you a better physician. So good morning.
Thank you, Dr. Abanilla, for your kind words of welcome. Up next, to give us a special message, may I call on the Division Chief of Vascular Medicine, Dr. Joel S. Paz.
Hello. Morning, everyone. Happy New Year. Happy Valentine's. This is the third change of an impromptu role that I'm going to do. But I'm glad to stand up here because this is an important event to me. I still remember 3 years ago exactly of the same month, my announcements were about the eruption of the Taal volcano and the super typhoon, I think that was Tisoy. And the resounding message was that if we could have prevented and followed some of the policies, the disasters would have been lessened. Now, 3 years later, I think the COVID disaster the impact is cannot be underestimated to all of us. That is why I'm glad to put forth some of the programs we are encouraging everybody, because prevention probably is not a small word anymore, but it's probably the biggest word of our decade. Okay, prevention because of the COVID, because of the vaccine, we are now here again standing up face to face. And through all these years, I guess what we learned are awards of warriors, of champions we have here amidst our place. This venue has put forth some of the Hall of Famer champions of BTE, like Dr. Abola, Dr. Mateo, Dr. Digia. Dr. Abanilla mentioned a lot of vascular medicine, but I think in all throughout these years, the pulmonary department and critical care department is with us through VTE prophylaxis. Now, the COVID has put forth and shown the resiliences and sacrifices. That's why we have Warrior Awards and Champion Awards. And to me, a warrior is somebody who is sacrificing with resilience, with probably a spice of gallantry on top. That is why we are launching more programs, because I know some of you are new faces, and I'd like to welcome the pre-fellow, because we'd like to make some champions also, future champions and future warriors of PTE prevention through these programs. So again, I welcome you, and I'm officially opening the VTE prevention, and welcome, and everybody happy Heart Month. Thank you.
Thank you, Dr. Paz, for your meaningful yet sudden message. Today, as one community, the Philippine Heart Center is launching its VTS Awareness Week. As we all know, VTE or venous thromboembolism is one of the most preventable causes of in-hospital morbidity and mortality. As we strive to improve the quality of our services and dedication to our patients, it would be helpful for all of us to know the fundamentals of this dreaded illness. As such, the Division of Vascular Medicine, together with the Division of Pulmonary and Critical Care Medicine, have produced a series of podcasts that would enlighten us on how to prevent VTE in the inpatient setting. To formally present these podcasts to our community, we would like to introduce one of the brains behind this project. He is the current head of the section of EAD and vascular rehabilitation in the Division of Vascular Medicine. My dear colleagues, let us all welcome Dr. Paulo Joel T. Nocom.
Thank you. Hi. Good morning, everybody. Of course, there's already great messages from our dear mentors. Of course, Dr. Joel Pass also introduced us on what are the guidelines, or what are the things that we need to perform. No? But of course, I'm not going to take the credit on the VTE Safety Zone Committee. We have the regional, Dr. Abola, who created, as well as with Dr. Digia, who created the VTE Safety Zone Committee. This is regionally, it is um, a clinical tool for the hospital to be utilized for VTE prevention. This is something that is out of the love of work and something for the love of our patient. And eventually it developed to a form that it is now a standard in our institution. So with that, I think that was a late 2000 when the VTE Safety Zone Committee was already put place. And eventually there was VTE Safety tool, the risk assessment tool that has been utilized by the institution. And fast forward 2017 that we have updated the VTE tool for the hospital. And historically, this is something that we enjoyed together during the Philippine Heart Center anniversary, that we include the VTE Safety Zone awareness campaign. But of course, we are cognizant there are a few things that may have an impact in the low output, meaning medyo hindi ganun ka-utilize yung tool. And there's a lot of reason. One of the one who's responsible for VTE risk assessing on the patient is the clinician as well as the nurses. And of course, there's a lot of changes, medical staff are coming in, and after 2-3 years, it will be out in the hospital. The nurses, of course, will have fast change. There are a lot of movement within the hospital. So meaning maybe 2-3 years from now, some of the staff are looking for places to work outside of the hospital. So the drawback here is that we are trying to educate. It's like a once-a-year event. No, we try to innovate by making it like a quarterly event, but unfortunately, the COVID hit everybody, and of course, all of you already had a fair share of the horrors, no? And that already created, I would say, a barrier in trying to educate. This is one of the first meeting again face to face on the VTE, but now we are trying to innovate, more accessible, a more, I would say, not a didactic thing, but this is something that would have an on-demand activity, meaning after the presentation on this group, the VTE podcast now would be embedded in the Philippine Heart Center website. So this is something that even if you're not around during the launching, now you could watch it on demand at the comfort of your home or wherever you have the time and opportunity. Now, the other thing that we have here, although may not be presented, is the VTE awareness among our patients. So we're not just educating the clinicians, the nurses, or any of the staff, the hospital, but rather we are also now touching the patient and the relatives. Now, that's something that the VT prevention is not something that is falling upon the institution itself, but it is a 360-degree, like our patient is also part of that, the relatives that would have a reduction in the VT occurrence in the hospital. Now, we'll be presenting this one, and in the future, we will be having more of the podcasts. As shown here, one of the first podcasts is knowing what is VTE. The second is what are the risk factor for VTE. The third is how are we going to prevent a VTE. That is something that is already available in our institution. And the last of the episode for this launching is how to risk assess using the VTE form in our institution. Of course, we're cognizant as well that there are a few changes in the hospital that you may find little quite different, no, from what is in the hospital. But then again, we are looking for innovative ways to improve the outcome, to improve the output of our institution in preventing the VTE. With that, I will not take more time. No, I would like you to sit back and enjoy, learn new stuff, or review some of the key points on VTE prevention. So with that, thank you and good morning. And VTE, no? So para siyang short movie screening. All right. So likewise, I've seen a lot of my colleagues from the nursing department, from the Division of Vascular Medicine, my mentors, and from the Division of Pulmonary Medicine, as well as the new faces of our pre-fellow, which will be the front lines in the floors, and eventually you will be the one to teach your colleagues in the future. All right. So with that, thank you. Thank you.
Magandang araw po sa kanilang lahat. I'm Percival Punsal. I'm an adult pulmonologist from the Philippine Heart Center. And today we are privileged to have one of our more prominent graduates. Walang iba kung si Dr. Pai Mateo. Siya ay isang adult pulmonologist din. And siya ay nag-specialize sa mga pulmonary vascular diseases. Hi, Dr. Pai.
Hi, good day, sir.
Now, ang topic natin ngayon ay tungkol sa venous thromboembolism. Dr. Pai, ano ba ang ibig sabihin ng venous thromboembolism?
So, ang venous thromboembolism po ay isang kondisyon wherein yung merong blood clot within a blood vessel. So, there are two conditions po doon. Under this is your deep vein thrombosis as well as your pulmonary embolism.
Ang susunod kong tanong sa iyo is, what is a clot? Ano ba yung pag sinabi nating clot sa ating pasyente?
So usually po, the blood in our body has a mechanism wherein it allows to be in liquid state initially, especially in normal conditions. Now, when it becomes solid, this is occurring in cases wherein there is a damage in your blood vessels. Now, a clot is a solid mass of blood that stick together and forms together and thicken, so containing your blood platelets, cells, and proteins. So this may be attached to the blood vessel itself. Now, at times, sir, yung blood clotting may be good when there is a damage in the vascular tissue, causing it to contract and to reduce the blood loss, especially the platelets now group together and becomes a plug to prevent further bleeding. But in cases wherein this may be dangerous, when it forms in cases wherein there is difficulty of the circulation of the blood, there is a risk now for developing your solid mass, which is known as your clot.
Dr. Rapay, can we differentiate between a thrombus and an embolus?
Yes, sir. So, ang thrombus po is a clot, no? So, this contains your fibrin, platelets, red blood cells that forms in your blood vessel. So, it is stationary. So, hindi po siya gumagalaw within the blood vessel. But once you have your embolus now already, so this clot now, which is attached to the blood vessel, is detached, no? And it breaks off as well as breaks loose. So this is transported by the bloodstream until it becomes lodged into a major vessel, especially your pulmonary artery.
So essentially, it's a material coming from a blood vessel na na-detach, lumangoy at pumunta doon sa blood vessel doon sa loob ng ating baga, right?
Yes.
Okay. Now, is there such a thing as a red or a white clot or thrombi?
So there are two types of clot, no? We have your red clot or your white clot. So what is a red and white clot? So ang red clot po, this usually forms in a low pressure system such as your venous system, so venous area ng body natin, and your cardiac atria. So this is rich in your fibrin and trap erythrocytes, and it is triggered inside the blood vessels, although in some, there is no obvious injury. Now, for your white clot naman po, sir, this is formed under a high shear pressure in the arteries, and it is more permeable. So, this usually is seen sa mga coronary arteries, no? Wherein there is stenotic artery, and such as in this case, some of these patients could be having atherosclerotic lesions. Now, this is rich in platelets, your von Willebrand factor and collagen calcification, and white blood cell, and usually there's active inflammation. So usually, sir, this is more stiffer and more stent, no? Accessible for stenting. Yeah.
Actually, kanina, no, dinescribe mo na yung venous thromboembolism, no? Can you reiterate yung explanation, no, para maintindihan tayo ng ating mga tagapanood ngayon?
Yes. So, yung venous thromboembolism po talaga is a condition, no? So, it encompasses two conditions. Let me reiterate again. Those two, these are your deep vein thrombosis and your pulmonary embolism. So, what happened is that there is a blood clot within the vessel, and at times this would dislodge and break off to become your embolus. So, that's why from the deep vein, there is a thrombus that dislodges into the pulmonary artery. So usually, sir, yung kasi, ang venous thromboembolism goes undetected, no? Until it's too late. So ang mga pasyente natin, pag meron ng simptomas, dun lang pumupunta sa doktor, no? So approximately 80% of our deep vein thrombosis are usually silent. Now, once it is detected only post-mortem, so pag namatay na yung pasyente, about 70% of them have fatal pulmonary embolism.
Okay, that's a very important message, ano? So dun sa mga nakikinig o nanonood sa atin, ano, be very aware na this type of disease can be fatal.
Yeah.
Okay. Now, what are the signs and symptoms of venous thromboembolism?
So start tayo sa deep vein thrombosis, sir.
Okay.
So for your deep vein thrombosis, sometimes sabi ko nga, there is no symptoms unless they would be now complaining of throbbing, tenderness, or cramping pain over your left or right leg, no? And it could be also present in the upper arm, no? So there would be some swelling, also some redness or bluish discoloration of the area, and there will be warmth, no, on the leg or arm. Yeah.
How about pulmonary embolism?
Sa pulmonary embolism naman po, at times, no, we don't usually see patients only with pulmonary embolism.
Mhm.
There is a concomitant deep vein thrombosis at times, no? So, ang presentation would be sudden breathlessness.
Okay.
There is chest pain, no? Very sharp siya. Then, at times, there will be coughing and coughing up of blood. And there will be increase in your heart rate, so tachycardia. And at times, because of, if it is massive, you'll be having some headache, dizziness, and eventually, sometimes you have syncope.
Okay. Thank you very much, Dr. Rapay. No? Marami kang binanggit na mga importante na dapat malaman ng mga nakikinig sa atin ngayon. Ano? And I hope na maalala natin itong mga nabanggit ni Dr. Rapay kasi kung makakita tayo ng mga pasyenteng may halintulad na nararamdaman, kailangan magpatingin sila sa doktor. Thank you very much, Dr. Rapay.
Thank you
po
very
sa inyong
much.
pakikinig ngayon. Magandang araw po sa kanilang lahat. Ano? I am Dr. Percival Ponsal. I am an adult pulmonologist dito sa Philippine Heart Center. And today we are privileged to have Dr. Pai Mateo. No? She is also an adult pulmonologist dito sa ating hospital. At siya ho ay nag-subspecialize sa pulmonary vascular diseases. Magandang araw, Dr. Pai.
Magandang araw din po, Dr. Punsal.
Okay. Dr. Pai, meron akong isang importanteng tanong sa iyo. No? Ano ba ang risk factors para mag-develop ka ng venous thromboembolism? Can we discuss it on a patient point of view and in a setting point of view?
Okay. So usually, ang sabi nga natin in the previous meetings natin, ang venous thromboembolism comprise the different clots, no, within the blood vessels. And this comprise two conditions, that is your deep vein thrombosis and your pulmonary embolism. Now, in these two conditions, blood clots may affect any age group. No? So, these factors may predispose as well as in the increased risk for thrombus formation, producing a serious and potentially fatal complication called your embolism. Now, here, you see that venous thromboembolism is the most preventable cause of in-hospital death. So, we have to have paramount prevention among these cases. So, it is multifactorial. So, according to the virtuous triad, no? So, this comprises three factors, no, for developing your VTE. Number one is slowing of your blood flow. So, kapag ang dugo ay masyadong malapot, so there's difficulty in the circulation, slowing of blood flow, that is one factor. Another factor, there is damage now to your blood vessel wall. So if there are injury now, so that would be a factor also. Another one is increase in your coagulability. So masyadong malapot yung dugo. So there's an increase in coagulation factor, no? Now, you see here that there are conditions that would promote, number one, yung slowing of your blood flow. Ano-ano yon? If you are immobilized, so some of our patients here in the hospital, if more than 3 days na nakahiga, no, sa kanilang hospital bed, these persons are prone to develop your VTE. Another one is yung venous obstruction. So may mga patients tayo na masyadong maraming taba, no?
Mhm.
So yung mabigat din sila. At the same time, those pregnant women are also prone for having slowing of blood flow. As well as mga patients natin also with atrial fibrillation. So ito yung mga merong problema sa left side of their heart, no?
Yung
Left
atrial fibrillation, ito yung irregular ang pagbeat ng puso, ano?
Yes.
Kaya sila
Ah.
predisposed dito sa condition ito.
Yes. At the same time, mga congenital abnormalities natin that affects the venous circulation. Ano ito? Marami. Pero mostly there are syndromes for this type of patients. As well as those patients with low blood pressure. So pag masyadong mababa yung blood pressure nila, so they're slowing of the blood flow. Now, for those patients now with vascular damage, so yung tinatawag na blood vessel wall injury, ito yung mga pasyente natin na palagi nating nilalagyan ng mga venipuncture, no? As well as mga indwelling catheter, no? Pati mga heart valves, no? So this could also damage your blood vessel wall. As well as those patients with atherosclerosis, ito rin may damage din. And of course, mga physical trauma, strain, or injury within the blood vessel could also promote vascular damage. At saka may mga pasyente tayo, di ba? Mga thrombophlebitis. Yung mga na blood IV na nadidislodge tapos namamaga yung area niyo.
Siguro, Dr. Pai, para ma-emphasize lang natin, lalo na sa ating mga healthcare worker na directly dealing with our patients, na yung mga binanggit mo ay napaka-importanting malaman nila because these are things that can predispose our patients dito sa kondisyong ating dinidiscuss ngayon.
Yes. So yung pangatlo na sinasabing risk factor is your increased coagulability. Ito yung mostly our patients having yung mga major surgery, yung mga patient nating who undergo coronary artery bypass, so mga congenital disease, mga na-patch natin, no, ng defect. So it could also promote hypercoagulability. As well as those pati infection pala at saka sepsis could also promote hypercoagulability.
So when we say hypercoagulability, ulitin natin, ito yung nagiging mas malapot
Yes.
ang dugo. Kaya
Yes.
nagkakaroon ka ng possibility nitong ating venous thromboembolism.
Yes.
Okay.
At the same time, meron pa rin pala mga inflammation, no? Dehydration, no? At saka yung mga pag-inom-inom ng mga estrogen therapy. So yung mga nagte-take ng pills, no? Particularly in our women of age, no? Hindi naman yung childbearing age. Yun.
Okay. So again, dun sa ating mga tagapanood ngayon, tatlong kondisyon na under sa Virchow's triad ang pwedeng magbigay ng venous thromboembolism, malapot na malapot na dugo, damage sa blood vessel, at saka yung stasis ng dugo sa ating blood vessel. Dr. Pai, how about yung mga strong predisposing factors?
Sir, yung sinabi natin, di ba, meron tayong patient-related at saka setting-related.
Yes.
Usually, pag patient, within the person, no, pasyente. Pero setting, baka may nangyaring ibang klase outside force na nag-cause nung condition na yon. So particularly pag nag-fracture tayo, 'di ba? Ng hip or leg, baka nahulog siya. So nagkaroon ng hip or leg fracture. So sa mga pasyente nating nagkaroon ng hip replacement or knee replacement could also be a strong predisposition to develop venous thromboembolism, as well as any major general surgery. So lahat ng mga pasyente natin dito almost undergo surgery, no? And major trauma as well as spinal cord injury.
Okay. Yung moderate predisposing factor.
So marami ding causes ng moderate, no, predisposing factor. So ano-ano 'yon? It could also be patient-related and setting-related again, no? So sa mga predisposing factor na setting-related, pag moderate, ito yung mga, sabi ko nga, outside forces. So may patient underwent surgery, nilagyan ng central venous line, binigyan ng chemotherapy, tapos buntis, no, ng pasyente. Pero pag patient-related na yan, lahat mga pasyente natin na may chronic heart and pulmonary failure. So may mga pasyente tayo ditong sa heart center. At the same time, meron din tayo, may mga cancer, nag-take ng contraceptive pill, mga stroke patients natin, no? Nag-hormonal replacement therapy, as well as yung mga postpartum natin na mga buntis, no?
So marami marami pala ang pwedeng maging dahilan ng pagkakaroon ng venous thromboembolism na considered as moderate. How about naman yung weak predisposing factors?
So this means that even weak siya, predisposed pa rin to develop your VTE.
Okay.
Yun nga lang, hindi siya masyadong iniintindi natin, but these are very important also. Risk factors for developing your VTE. Ano-ano ito? So, sabi ko nga kanina, kapag ang pasyente nahiga more than 3 days sa hospital bed, that could be a predisposing factor already. At the same time, kaya nga lahat ng pasyente natin post-op, pinapa-mobilize na natin, pinapatayo, sit, no? Kasi nga, this could also be a predisposing factor to develop VTE. Lalo na sa mga pasyente also natin na malayo ang nilalakbay, no? Yung mga pasyente natin from kunyari Ilocos papunta dito sa heart center para magpagamot. This could also be due to a prolonged car or air travel.
So
Pwede
yung
yun.
mga nakaupo ng maraming oras.
Yes,
Okay.
oo. Lalo na pati mga pasyente natin matataas ang ang mga aged persons natin. Most of our patients here are elderly. Tapos noon, at the same time, those with laparoscopic surgery, mga mabibigat ang timbang, mga obese patients natin, at saka yung merong varicose veins na we usually see in our patients. Of course, those patients also with pregnancy, antepartum could also be a weak factor, but this could also precipitate venous thromboembolism.
Marami na naman tayong natutunan mula kay Dr. Pai. Dr. Pai, thank you very much for spending this day with us. And I'm sure maraming leksyon na napulot ang ating mga tagapanood ngayon. Thank you very much po sa mga viewers mo namin at this time.
Thank you very much.
Good day, everyone, and welcome to our podcast. I am Dr. Kevin Michael Yu, Chief Fellow of the Department of Adult Cardiology at the Philippine Heart Center, and I welcome you back to our annual VTE Awareness and Screening Week. Going over our previous podcast sessions, we began by discussing the definition of VTE before highlighting its risk factors. We will be educating you on VTE prevention today. As previously stated, although VTE can be harmful in terms of its effects and complications, it is indeed preventable. We must all have a high clinical suspicion for this medical condition and recognize who among our patients is at risk for developing VTE. I'd like to once again welcome our distinguished guest, Dr. Paulo Nocom, a vascular medicine specialist and a member of the VTE Safety Zone Committee of the Philippine Heart Center. Good day to you, Doctor, and welcome.
Hi, Kevin. Thank you for that kind introduction. So, I'm glad that we're back here for the podcast for the VT awareness. Go ahead.
So without further ado, Doctor, let's get to the heart of the matter. How can we prevent venous thromboembolism?
Thank you, Kevin, for that opening question. So before we start talking about thromboprophylaxis, it's also important to remember that on low-risk population, we don't need to start any anticoagulation. Rather, we ask patients to be able to ambulate as often as possible, until probably upon discharge. And we advise this individual to move around their legs. So igalaw-galaw yung binte, we ask them to move their legs. So this would improve the circulation, the lower extremity, thereby improving the blood circulation and reducing the chance of venous thromboembolism. Now, on the other hand, to identify patients with moderate or high-risk VTE, now that's the time we need to fulfill the assessment using the VTE risk assessment form that is available in our institution here in the Philippine Heart Center, especially for hospitalized individuals. And those, we can categorize this patient in accordance to their risk from coming out from low, moderate, or high risk. Now with that, this will help us identify who among the target population that would necessitate prophylactic measures.
Thank you, Doctor. So which reminds me, do we have another session for that to guide our healthcare workers on how to accomplish the VTE risk assessment form? So after we identify the risk factors, what do we do next, Doctor?
Yeah, so we can likewise apply the various scoring system or our risk assessment tools in this institution. Now, we have several, in fact. No, we please don't get overwhelmed on the multiple risk factor assessment tool that may be utilized. Now, just to name a few, of course, we have the IMPROVE VTE risk assessment tool. We are also aware of the PADUA risk tool. For surgical individual, of course, we could utilize the Caprini risk scoring. And let's say a patient who were admitted for cancer, then we could likewise utilize the Corana risk scoring. Now, we can risk stratify the patient and perhaps start prophylaxis accordingly, depending on the risk of the patient.
All right. So these scoring systems are indeed very, very useful, especially for us health workers. So if our patient is able to fulfill the criteria for high risk for VTE, do we immediately start prophylactic treatment?
Right. So that's a great question. Now, first, we need to risk stratify patients to receive pharmacologic prophylaxis. Is our patient a good candidate to begin with to starting anticoagulation therapy? Now, the issue here is we must determine if there's any absolute contraindication or even relative contraindication. Is our patient in danger of bleeding? There's a risk of bleeding for this patient. Now, if the patient is high risk, then that is something that we need to modify. Perhaps we're going to use a different strategy to reduce the risk for VTE. Now, at present, we are using the HAS-BLOOD scoring. That is a way of checking a lot of the parameters that is also available in the VTE risk assessment form. And this will give us an insight if the patient is already at risk for bleeding. There's multiples of, there's parameter of the bleeding. There's also checking the utility of antiplatelet, the utilization of NSAID, if there's a liver dysfunction, if the patient is alcoholic, if the platelet is quite low, or there are other multiple reasons. Now, we have already a new modality coming up very soon for this institution, the improved bleeding risk scoring, which is a more powerful tool for assessing the risk of bleeding for the patient. Now, of course, there are other absolute contraindications. You know, if the patient has ischemic stroke recently within the last 6 months, a recent trauma within the last 30 days, patient have history of hemorrhagic stroke or CNS neoplasm, or there's an absolute bleeding diathesis, then perhaps those individuals may need a different approach for VTE thromboprophylaxis. No?
All right, so wow, that's a lot of information. So to recap what we have discussed at this point, it is important that we identify risk factors using the VTE risk assessment tool and apply the various scoring systems to determine the risk for venous thromboembolism. We then check if there are any contraindications for starting pharmacologic prophylaxis, such as the bleeding risk of a particular patient. Now the question is, which anticoagulants can we start for our patients?
Yeah, that's a great question, Kevin. Now, it really depends on the population that we, being involved. Now, provided that they don't have any contraindication, please be reminded, contraindication, we need to risk assess the patient. For medically ill patients, now we can start low molecular weight heparin, such as enoxaparin, 40 milligrams once a day subcutaneous injection. We could also use the tinzaparin at 3,500 milligram or units for subcutaneous given once a day, or unfractionated heparin every 12 or every 8 hours, depending on the renal function of the patient. Now, if you have a patient have a heparin-induced thrombocytopenia hit, then I think that will have a utility if you're going to use a factor 10A inhibitor such as fondaparinol, 2.5 milligrams once a day as an alternative. Now, for those who have contraindication for the pharmacologic approach, then we could utilize mechanical thromboprophylaxis, such as your graduated compression stockings, the anti-embolic stockings, that's very popular in most of the institution. Also, here in Philippine Heart Center, it's also available the intermittent pneumatic compression that, we could give out to our patients, okay? So that it will be employed for risk reduction. Now, here's the deal. If the patient is at a very high risk to develop venous thromboembolism, then I think it's rightful to utilize both pharmacologic and mechanical thromboprophylaxis.
Okay, but enoxaparin, tinzaparin, and your your unfractionated heparins are administered parenterally.
Yeah.
How about oral anticoagulants, doctor? When is the best time to use these?
Yeah, it's another question. Now, it's something that is really exciting. Is there any oral anticoagulants that's readily available? But specifically, if we're going to utilize the DOACs, direct oral anticoagulation, that is best in patients who have underwent orthopedic surgical intervention, such as knee replacement or hip replacement surgery. Those have a good paper to reduce venous thromboembolism in this individual. However, if there's a concomitant, let's say atrial fibrillation, there's a need for anticoagulation, of course, there will be utilizing a more of a higher dose of anticoagulation that is, of course, for the prevention of cardioembolic stroke. So that's a different thing. We don't need to reduce the dose for thromboprophylaxis, but rather this is to protect them for cardioembolic event. So with that, I do believe our audience, our listener, will be asking their attendings if there's such case needed to give an add-on VTE prophylaxis, or we could just use the AF, the atrial fibrillation dose for cardioembolic protection, right?
Yeah, that's a very, very interesting point. How about for our patients who require anticoagulation but have contraindications such as bleeding? How can we manage these patients?
Yeah, that's a real question. Now, if the patient's quite bleeding or have a very recent risk of history of bleeding, then I think that were the mechanical thromboprophylaxis, such as again your anti-embolic stockings, then the intermittent pneumatic compression. But mind you, please assess our patients if they have peripheral artery disease. If you're going to utilize this kind of mechanical compression devices, we want to know if they have PAD, if they're symptomatic for PAD, if there's already an gangrene or there's already rest pain. Those individuals may have a contraindication as well to utilize the mechanical thromboprophylaxis, such as also in individuals with active heart failure. We don't want to push the leg, the fluid on the leg going back to the heart, and this may predispose acute decompensation of the heart failure. So those are the two things that we need to keep in mind. Of course, lastly, if the patient have already diagnosed with deep vein thrombosis, and I think that's also one of the contraindication using the mechanical thromboprophylaxis. And I think that time that we need to treat the patient with DVT, okay?
Right. So, for example, doctor, we have already decided for our patient that we have to give anticoagulant as prophylaxis. And then we have already established that there is no contraindication. How long do we give this prophylaxis?
Okay, that's a real question. Now, if your patient has been receiving, there's no contraindication, okay, that's great. Now, how long? Until such time that the patient is able to ambulate, okay, as long as the patient is ready upon discharge, then you could discontinue the VTE prophylaxis over the patient. However, there are subsets of patients that may need prolonged VTE prophylaxis. This is a highly selected individual who have a very high risk to develop VTE even after discharge. So there are modalities for that, and perhaps we're going to go back here again for another podcast for those individuals. A lot of topic covering the COVID and the VTE, those who have, or individual who are on mechanical ventilation, of course, until such time that the patient has been weaned off successfully and prior to discharge, and those individuals may require a prolonged anticoagulation while he or she is on the ventilatory support.
Thank you very much, Dr. Nocom, for your very valuable inputs. So indeed, we have very, very good information here. And these are concise and essential information for us. So thank you again, Dr. Nocom, for sharing to us your valuable expertise. Now, to summarize the important key points of this podcast, the decision of starting venous thromboembolism prophylaxis would depend on the predisposing factors of the patient. This is determined by following the VTE risk assessment tool that we use in our institution and various scoring systems such as the PADWA risk or the improved scoring. We then risk stratify our patients for thromboprophylaxis. If there are no contraindications, we can give parenteral anticoagulation like our low molecular weight heparin or fondaparinux for our hospitalized patients. The duration of the anticoagulation is determined and continued until the patient is fully ambulatory. The decision to extend will depend on the functional capacity of the patient, especially if they continue to remain immobile. So for our final podcast, the scope will include educating our health workers on how to fill up the VTE risk assessment tool. Stay tuned, everyone, and thank you once again.
Thank you.
Good day, everyone, and welcome to our podcast. Once again, I am your host, Dr. Kevin Michael Yu, Chief Fellow of the Department of Adult Cardiology of the Philippine Heart Center. And I welcome you back to our annual VTE Awareness and Screening Week. After discussing what VTE is, its risk factors, and principles of prevention, let us now go over something which is more specific, the VTE assessment form. Let's all welcome back our distinguished guest, Dr. Paulo Nocom, a vascular specialist. Good day to you, doctor.
Great day to you, Kevin. Thank you once again for the kind introduction. Now, for this podcast, I would like everybody to watch the video for the VTE risk assessment form on how to fill up, so that number one, you'll be able to identify the risk of the patient. Number two, be able to sieve out who are at risk of developing complication and what type of prophylaxis that could be given to the patient. And with that, I enjoin each and everyone to watch the video. And this is something that will be able to go back again on demand. Okay. How are you doing? So for this session, we'll be having a VTE form awareness. This is brought to you by the VTE Safety Zone Committee. So this is the topic outline is getting acquainted with the form, how to feel and interpret, what to do if high risk for bleeding, how to order, who will be in charge of this form, where does this form go, and your role as assessing the patient. So why are we doing this? Of course, this is to risk assess our patient for potentially preventable problem. And of course, this will not to add to the burden of the patient and family. If so, the patient have a VTE. And this will become a healthy habit for all healthcare provider as a vision of the VTE Safety Zone Committee and this institution. So this is the available VTE risk assessment tool that's already utilized by the institution. Please do not be overwhelmed as we go one segment at a time, so for you to understand. So this is in the upper left corner, which is the red one. Red means a lot because one of this is already categorized as high risk VTE, okay? High VTE risk. And the recommendation will be anticoagulation and compression device. As enumerated, as you could see in the screen, active cancer, elective hip or knee replacement, patient have a serious trauma, spinal cord injury resulting to paralysis, patient had a stroke, history of prior DVT or pulmonary embolism, family history or history of thrombosis, age 75 and older with any moderate or VTE risk, reduced mobility or more than 3 points of the low VTE risk category. So with that, it's worth to note that an active cancer is diagnosed with the cancer. Active cancer is diagnosed with cancer, local or with metastasis, chemo and radiotherapy within the last 6 months. A history of thrombosis is defined as a carriage defect of antithrombine, protein C or protein S deficiency, factor V laden, and antiphospholipid syndrome. And reduced mobility, on the other hand, is defined as a bed rest with bathroom privilege as ordered by physician or patient's limitation for at least 3 days. And the recommendation is anticoagulation and compression devices. So moving on, for the yellow, which warns you, which would recommend if you have more than one, it's already considered as high risk. But if it's just one, it's considered still at moderate VTE risk. So the age is 60 to 74. Patient underwent arthroscopic surgery, major surgery lasting more than 45 minutes, or laparoscopic surgery, immobilization or immobilizing plaster cast for less than a month, a patient who was given or had central venous access for more than 3 days, or morbidly obese. Please take note, BMI of more than 40 for Caucasian, but for Asian, it's more than 27.5. To take note, more than one of this puts the patient on high risk. And if your patient is more than 75 years of age with one of this, then consider already high risk. So the recommendation is, of course, anticoagulation and or compression device. So you have a choice, either give anticoagulation or compression device or both. So moving on, for low VTE risk situation, you need to count, okay? If it's more than 3 that you have already checked, consider already as high risk. So the categories are age of 41 to 60, acute myocardial infarction, congestive heart failure, BMI of more than 25 but not more than 27.5. Patient have a sepsis, serious lung disease including pneumonia, COPD, medical patients on bed rest of under 3 days, a swollen leg, minor surgery or planned elective bypass surgery, Patient have history of prior major surgery of under 1 month, varicose vein, or history of inflammatory bowel disease. But do take note, if more than 3, then consider as high risk. You move up, you categorize on the combination of giving prophylactic parenteral anticoagulation and compression device. Otherwise, you advise the patient to walk. So this is specifically for female. Okay, a patient who is using OCP or hormone replacement therapy, or a patient who is pregnant or postpartum less than a month, or history of stillbirth, more than 3 spontaneous abortion, premature birth with toxemia, or growth-restricted infant. So that puts the patient 1 point each. Moving on, after we have risk assess our patient for risk in VTE, now we'll have the note for the bleeding risk. The question is your patient going to bleed? Now, these are the category for patients with high risk for bleeding condition. The abnormal baseline bleeding parameters, or active bleeding, or patient who is actively taking alcohol prior to admission, or elevated creatinine, or elevated liver enzyme, or has bled more than 3, or using this patient or using NSAID, aspirin, or clopidogrel, or the platelet is under 100. Now, any of the boxes are checked, patient may not be a candidate for pharmacologic prophylaxis. So these are the choices that we are going to give. Are we good to go? Now, if your patient for moderate to high risk, you have to choose one of this, specifically the anticoagulant that is available in the country, enoxaparin at 40 milligrams sub-Q every 24 hours, denzaparin at 3,500 sub-Q every 24 hours, or fondaparinux of 2.5 milligrams sub-Q every 24 hours, or unfractionated heparin of 5,000 units subcutaneously every 8 hours. On the other hand, patients who underwent total hip or total knee replacement may utilize NOAC on a separate sheet after this lecture. So for the compression therapy, you have to check for an active heart failure, as active heart failure is relative contraindication for the compression therapy. You also want to check for PAD symptoms. And lastly, but not the least, check for an acute DVT or superficial vein thrombosis. And if there's none, you may apply the anti-embolic stockings. You have a laterality. Let's say a patient have PAD on the right, then you apply the anti-embolic on the left. Okay? Or you could choose intermittent pneumatic compression depending on the availability in your institution. But here in the Philippine Heart Center, we do have intermittent pneumatic compression. Now, if your patient is having the good news of low risk for VTE, let's say there's no high or moderate risk factor, and low VTE risk factor score sum is under 3, then we may advise the patient to ambulate during waking hours as often as possible with fall precaution. Also, if the patient is unable to move around, then we may encourage them for movement of legs. Now, this is important here that we need to reassess risk and VTE prophylaxis order every 3 days and or during the transfer to another unit. Let's say from non-critical unit now being transferred to a critical ill unit. Of course, there's a clinical change, then we may need to recheck our VTE risk assessment for the patient. Again, let's not forget that one. Moving on, we need to take pride in our work. So who are the responsible individuals? It is the bedside nurse, the house staff, and the attending physician. But please do take note, the form GO, now it will be placed on the physician order divider as part of the doctor's order. Now, for the attending physician to counter-check our work and to decide. Again, the VTE risk assessment tool will not take away the clinical judgment from the consultants or any physicians. It's still the attending physician's decision when and what to do The form is just a guiding tool to the end user what are the risks of the patient and suggest treatment plan. The form is a way of getting details that may not reveal in a targeted history taking. We all share, of course, a responsibility for the welfare of our patient, doctors, nurses, and the institution. I thank you for your kind attention.
Well said, Dr. Nokom. Thank you very much for that information. That ends our first set of podcasts. Stay tuned for more series of podcasts in the future. Once again, I would like to thank Dr. Nokom for sharing his expertise with us. I hope all our healthcare professionals have learned a lot in this short podcast. By the way, all these videos will be available on demand on the PHC website. That's www.phc.gov.ph. Please feel free to share this information to everyone, and you can watch all these videos at your convenience. Thank you once again, everyone, and see you around. Magandang araw po sa inyong lahat. Ako po si Dr. Kevin Michael Yu, Chief Fellow ng Department of Adult Cardiology ng Philippine Heart Center. Welcome po sa inyong lahat dito po sa ating isang maikling programa na inihahandog po ng Philippine Heart Center para sa ating mga minamahal na pasyente at kanilang mga kamag-anak. Ipinapakilala ko po ang ating mga panauhin ngayong araw, si Dr. Paulo Nokom, isang vascular medicine specialist, at si Dr. Maria Paz Mateo, isang dalubhasa sa baga at sa mga ugat. Welcome po, Doktor.
Magandang araw.
Magandang araw.
Magandang araw din sa lahat ng ating mga taga-subaybay.
So, Dr. Mateo, maitanong ko lang po, ano po ba ang ibig sabihin ng VTE o ng venous thromboembolism?
So, ang venous thromboembolism ay tumutukoy sa dalawang kondisyon. Ito yung tinatawag na deep vein thrombosis, which is, namuong dugo na nagbara, no? Na nagbara sa ugat ng puson, hita, at saka mga binte. Yung isang kondisyon naman ay ang pulmonary embolism. Ito naman po yung mga namuong dugo na nagbara naman sa ugat ng baga. Now, in these cases po, mostly ang pulmonary embolism po ay nanggagaling po dito sa deep vein thrombosis na yung namuong dugo ay lumakad papunta sa ugat ng baga. So that's why ang tawag po dito venous thromboembolism.
Naku po, nakakatakot naman po ito. Ano po bang mga sanhi ng pagkakaroon nitong venous thromboembolism?
So maraming sanhi ang venous thromboembolism. So isa na dito, siyempre mga pasyente natin dito sa Philippine Heart Center ay may katandaan na po, no? So mga elderly individuals are prone to develop VTE. Isa pa po ay mga pasyente nating buntis. Pwede rin po yun. Lalo na po yung mga ating childbearing patients na umiinom po ng mga contraception. Isa pa po doon ang mga pasyente natin may cancer. So lumalapot po ang dugo nila. So nagkukos din po ng venous thromboembolism. Mga pasyente rin po natin na mabigat ang timbang, mataba, ano? So this could also promote venous thromboembolism. At saka po, lalo na po mga pasyente natin dito na nakahiga for more than 3 days, lalo na sa ospital, nakaka-cause po yun ng paglapot ng dugo. Isa pa nun po dito ay ang operasyon. Most of our patients dito sa Philippine Heart Center undergo surgery, major surgery in the form of pwedeng yung mga coronary artery bypass grafting, mga pagsara ng mga depekto sa mga congenital heart disease, at saka yung mga sa lower extremity po, no, sa mga binte, yung mga stripping na ginagawa ng vascular surgery. No?
Okay, so for example po, Doktora, ang isang pasyente magkakaroon ng VTE. Ano po ba ang mga sintomas na pwede niyang maramdaman?
Okay. So ang mga nararamdaman, lalo na mga pasyente nating may deep vein thrombosis, makikita nyo masakit, no? Nananakit ang hita, pati paa, hanggang paa. Now, kuminsan nagkakalagnat po sila, no? Kuminsan mainit yung area na involved na lower extremity or binte, no? At paa. Pwede rin ho namamanas siya. Lalo na yung isang part ng isang leg natin or binte. Oh, you can see also here dito sa ating taas na bahagi ng mga kamay at mga braso. Pwede rin ho natin makita yon. At the same time, pamumula, so warmth, no? Redness do sa apektadong paa or binte. Of course, makikita rin ninyo paglaki ng ugat din do sa area na yon. Yun po ang mga pwedeng maramdaman ng isang pasyenteng may DVT.
Pulmonary embolism. Ano naman po ang sintomas ng mga pasyente?
So, usually mga pasyente nating may pulmonary embolism ay nakakaranas ng pananakip ng dibdib, no? At saka at the same time, paninikip ng dibdib. So usually, hirap silang maghuminga at umuubo ng dugo. At kuminsan, makikita mo, nangingitim ang kanilang labi at saka mga daliri na involved na merong pulmonary or embolism, no? So, kuminsan, pag masyadong madami yung thrombus or embolus or yung namuong dugo na pumunta sa ugat ng baga, mahihimatay ang mga pasyente.
Okay, salamat po, Doktora. Punta naman po tayo sa inyo, Dr. Nocom. Para sa mga pasyente naman po natin na nagkaroon ng DVT or pulmonary embolism, ano naman po ang mga komplikasyon ng sakit na ito?
Oo, Kevin, that's napaka-importante niyan. Ano ang komplikasyon ng venous thromboembolism? Sa totoo lang po, mga kaibigan, mga pasyente, mga kamag-anak, ang komplikasyon nito ay nakakatakot, nakakagimbal. Maaari pong kumitil ng buhay ng ating mga pasyente. Yan ang pinakaayaw natin mangyari. Bukod dyan, yung mga pangmatagalang komplikasyon mula ho doon sa binti, tinatawag natin na post-thrombotic syndrome. Yan po yung sugat na hindi gumagaling doon sa binti. Napakasakit. Ang hirap gamutin. No? Pirming mahapdi, pirming namamaga, pirming namumula. Ayaw gumaling na sugat. So post-thrombotic syndrome, isa po yan sa komplikasyon. Another, paano ho yun doon sa baga? Kung nagkaroon ng pulmonary embolism, nakalusot sila. Maring nabuhay, pero ang komplikasyon niyan, yung tinatawag natin na chronic thromboembolic pulmonary hypertension. Isang uri po ng komplikasyon na kung saan yung namuong dugo ay naging peklat. Kalaunan, nagkakaroon ng alta presyon dun sa baga. Ang mangyari nito, ang mga pasyente, pirming hingal, pirming hapo, manas, malaki ang tiyan, malaki ang binti, no? Hindi po ito yung mga ordinaryong karamdaman na napakadaling gamutin. Ito po ay isang komplikasyon na nakakatakot. Di po ba, Ma'am Dr. Mateo, di po ba ito yung mga ayaw nating pasyente sa totoo lang, no?
So napakahirap na condition ito kasi mostly ang mga pasyente who develop na ganitong klaseng komplikasyon would rather be treated surgically, no? So para matanggal yung namuong dugo, no, nasa blood vessel or ugat ng malaking ugat ng baga, which is your pulmonary artery.
Madaling plano, operasyon. Pero sa totoo lang, di ba, doktora, napakahirap ng ganyang klaseng operasyon.
Yes, kasi the surgery or yung operasyon itself could be a magiging sanhi to develop another episode ng venous thromboembolism.
So hindi porke na operahan na sa ating mga taga-subaybay, Hindi po porke na operahan ay hindi na po magkakaroon bagkus, mataas pa lalo ang komplikasyon na umulit pa ito at gagamit siya ng habang buhay na pampalabnaw ng dugo, which is another peligro. Kasi maaaring maling gamot, maaaring gamit ng gamot, maaaring magkaroon ng komplikasyon, halimbawa ang pagdurugo. No? Kaya importante ito na iwasan natin.
Okay. So, syempre po, Doktor and Doktora, no, ayaw naman nating umabot sa gantong punto yung mga pasyente natin. Paano naman po natin maiiwasan ang pagkakaroon ng venous thromboembolism?
So, sabi nga natin, ang mga pasyente dito sa heart center ay nakaratay sa kanilang mga higaan, no? So, make sure na maaga silang gumalaw, lalo na kapag matagal na sila nasa ospital, no? At saka kuminsan sasabihin natin sa kanila, gumalaw-galaw naman po kayo. At saka kung maglakad, no? So usually mga pasyente nating na pagkatapos ng operasyon dito, usually nakaratay talaga sa higaan nila. So make sure na tayo na rin mga healthcare workers magsabi sa ating pasyente na pwede nang umupo, mag-ambulate, umupo na at eventually tumayo, then maglakad. Yan.
So tama po yun, no, Doktora, no? Napaka-importante nito. Tandaan po natin, di ba? Lagi po nakikipag-usap tayo sa ating mga manggagamot. Kung kayo po ay pasyente, magtanong po kayo sa inyong doktor. Pwede na ho ba ako maglakad? Pinapahintulutan niyo na po ba ako maglakad? No? Ganon din ho sa mga kaanak. Kung kayo po ay binigyan ng pahintulot ng inyong manggagamot na gabayan ng inyong pasyente, no? Tulungan po natin sila makalakad ng mas maaga. Mga karagdagan pa ho, no? Halimbawa yung pag-unat ng paa, kung ang inyong pasyente ay nahihirapan, magtanong po sa inyo ulit, sa inyong manggagamot o sa nurse po na nagbabantay, kung paano po kayo makakatulong para maiwasan po ang pagkakaroon ng venous thromboembolism sa pamamagitan po ng bilang kaanak na nasa tabi ng kama. Paggalaw ng bias, ng mga binti natin, no, sa ating mga pasyente, paano po makakagalaw, paano tayo makakaiwas. Meron pa po mga ibang paraan na ating ginagamit. Meron po tayong tinatawag na mga gamot na tinuturok, no? Pampalabnaw po yan ng dugo. Meron din po tayo mga sinusuot na medyo sa mahigpit o meron din po tayo mga kinakabit na mga instrumento. Para po doon sa mga karagdagang impormasyon, makipag-ugnayan po sa inyong mga manggagamot na kasalukuyan na nagbabantay po para sa inyo kung kayo po ay kwalipikado o ang pasyente niyo po ba ay kwalipikadong tumanggap ng ganong klaseng paraan para mabawasan ang tinatawag na venous thromboembolism.
Okay, so ayan po, narinig po natin ang tungkol sa venous thromboembolism. Maraming salamat po, Dr. Nocom at Dr. Mateo sa pamamahagi ng inyong kaalaman tungkol sa topic po na ito. I'm sure marami pong napulot ng ating mga pasyente tungkol sa VTE, sa sanhi nito, mga komplikasyon nito, at kung paano po natin ito maiiwasan. Patnubayan niyo po at subaybayan niyo po kami sa susunod po naming mga programang ganito. Maraming salamat po ulit.
Maraming salamat.
Thank you, Dr. Mateo, Dr. Punzal, Dr. Nocom, and Dr. Yu for this innovative initiative to spread VTE awareness. I think we can all agree that these series of podcasts are very informative. I, for one, have learned a lot just by watching them. I am sure that healthcare workers and our patients will also find them very useful. Now, we would like to call on the other brain behind this project for a special message. She is a specialist in pulmonary vascular medicine from the Division of Pulmonary and Critical Care Medicine. Altogether, let us welcome Dr. Maria Paz B. Mateo.
Thank you. Good morning po sa inyong lahat. So I hope that everybody has enjoyed watching the podcast, the 4 episodes. But yung 4 episodes na po na to will not be available probably very soon within our website of the Philippine Heart Center. Now, today, February 20, 2023, as I can remember, it was 14 years ago when there was an inauguration for the Center for Pulmonary Vascular Disorders. So this is also known as the Pulmonary Hypertension Clinic of the Philippine Heart Center. Now, after the 1 year later, Dr. Abola, together with Dr. Digia, has had made such this one, the VTE Safety Zone program. And so that was 13 years ago. So they were able to invite me to be part of this. So tatlo na kami. So what happened is that after 13 years, we were able now to launch another event, which is your podcast. So I'm very happy that Dr. Nokong was with us since 2017. And of course, Dr. Joel Paz since that time memorial na, no? So every year meron tayong BTE awareness program, no? Every February. But you see, as you see here, no? Dr. Digia has foretold already that this is a part of the requirement for accreditation for international and local organization such as your JCI and Canada, etc., and DOH. So I'm trying to tell everybody now is the time that we should have VTE nurse, no? Present, yung available, which is also because nanghihiram lang tayo. So we should have a dedicated nurse for this. And at the same time, as you see, kasi VTE, the heart center does not have any laboratory reagent for hypercoagulable state, no? So mga yan, protein C, protein S, antithrombin, no, etc. So the blood of our patients are being transported pa to other hospital. Kaya sinabi na namin kanina kay Dr. Abanilla prior to the nung umalis siya, no? So that's why I'm so grateful. So ito si Dr. Teresa Bola is very much aware that we are very fortunate that every year, even though na hindi kami binibigyan ng budget, we are still having this VTE awareness program. Now here yung podcast natin. So it's a 4 episodes. So you should watch it again dito sa ating mga cellphone, laptop, etc. Because if you're going to watch them, no, again, there will be a after evaluation for each episode. And after you have watched it and answered the evaluation, you will be given a certificate of completion that you have of course, watch the VTE awareness safety program of the organization. Okay, so thank you very much. So I hope na meron tayong magkaroon na tayong nurse, ma'am. Okay, thank you very much and happy Hearts Day. Thank you.
Thank you, Dr. Mateo. Now we would like to recognize the members of our community who have been steadfast in our fight against VTE. These include the nursing units who have been most compliant with current hospital policies in VTE prevention. To award the certificates of recognition, we would like to call back on stage Dr. Mateo, Dr. Nocom, and the Division Chief of Vascular Medicine, Dr. Joel S. Paz.
Just like to thank also our fellows, Dr. Sheikh Saturinas, and of course, Dr. Ralph, ano apelyido mo? Aguinaldo. Sorry. And also, our fellows from the vascular medicine for this podcast. So they are the one who did the ano yun, itong ano natin podcast. So thank you very much.
Just to add on lang po. Special mention to our vascular nurse, actually, kaisa-isa. Ma'am Cathy, where are you? Ma'am Cathy, hello. Hello. Show yourself, show yourself. Be proud. She's our one and only vascular nurse and as well as our lymphedema nurse in our institution. She's wearing multiple hats, no? So I hope na makonsider the institution will consider to have another one to help us out in this institution, as well as, of course, special mention to the rest of the institution. The current compliance before, I think 2017, parang low 20% lang po ang compliance in 2017. And right now, the institution is at 80%. So big, big hand for yourself who's already able to perform. However, there's still the 20% room for improvement. We're hoping for 100% compliance in this institution. So kaya naman, no? And this is part of our activity to educate, re-educate, reignite the idea. Hopefully that we'll be having more improved outcome against the VTE. No? So with that, we thank each and everybody and congratulations to the winners of the most compliant units. Back to you, Ma'am Sheila.
Thank you, Dr. Mateo and Dr. Nocom. With a 90% compliance rate, the third most compliant nursing unit is Petal 4F. May we request the representatives from Petal 4F to receive the Certificate of Appreciation. To receive the Certificate of Appreciation, Ma'am Bing Paligutan and Ma'am Bell, the OIC of Petal 4F and the Division Chief of the Certificate of Appreciation reads, this certificate is proudly presented to Petal 4F as the third most compliant station in the observance of the accomplishment of VTE assessment forms given this 20th of February 2023 at the Children's Grand Auditorium, Philippine Heart Center, Diliman, Quezon City. Congratulations, Petal 4F. And the second most compliant nursing unit with a 91% compliance rate is Petal 5C. May I call on the representatives and the head nurse of Petal 5C to receive the certificate of appreciation. Again, congratulations, Petal 5C. Ma'am Belle, I think you have to stay on stage. To remain on stage, go MS2 for the most compliant nursing unit with a 95% compliance rate. The most compliant nursing unit goes to Petal 5B. May I call on the representatives to receive the certificate of appreciation. Congratulations. Congratulations, MS2, and to our nursing units. May I request Dr. Mateo, Dr. Nocam, and Dr. Paz to remain on stage. Up next, we would like to award the certificate of appreciation to Dr. Maria Paz B. Mateo, Dr. Paolo Joel T. Nocom, Dr. Percival A. Punzal, and Dr. Kevin Michael Yu for their participation in the VTE podcast in the celebration of the Philippine Heart Center's 48th anniversary. The certificates are to be presented by Dr. Joel S. Paz, Division Chief of Vascular Medicine. Let us give them a big round of applause. Thank you, doctors. And thank you, everyone. And we would also like to extend our gratitude and appreciation to our fellows, Dr. Aguinaldos and Dr. Saturinas and Dr. Palmero and Dr. Miralles for organizing this event and this launch of our podcast. As we draw this program to a close, we would like to call on the head of the section of PAD and vascular rehabilitation in the Division of Vascular Medicine, Dr. Paolo Joel T. Nocom, for the closing remarks.
Thank you. Thank you, Ma'am Sheila. Thank you for hosting this launching of the podcast. And to all of our attendees, it is something that is quite exciting after 3 years. This is again a face-to-face activity. And this is another opportunity for us to learn and for us opportunity to educate each and everyone. Now, it's something na I would say this would reach more individuals in this institution as we are trying to innovate ways to reach more people. So we hope that you will have your own feedback, and in the future we'll be having also, I would say, a form of certification or a form that you will be certified as a VTE risk assessor as one of our programs in our institution so that we'll be having an enhanced way on saving our patients from the trouble. So I thank each and everybody for their kind attention and attendance, and we're hoping next year to have more innovative ways to try to reach professionals and our patients. With that, thank you for organizing the CRF of Vascular Medicine, the fellows on the pulmonary medicine, of course, the adult cardiology fellows, especially the chief fellow, Dr. Yu. Thank you for biglaan. And of course, our consultants who were ever supportive in the endeavors of the institution. With that, we draw to a close. Thank you. And I think there is a snack at the back for some refreshment for each and everybody. Enjoy the rest of the day. Happy week ahead. Thank you.
Thank you, Dr. Nocom. This marks the end of the launching of VTE Awareness Week. On behalf of the Division of Vascular Medicine and the Division of Pulmonary and Critical Care Medicine, we would like to thank everyone who attended this event. I hope we have all found this morning fruitful and enlightening. Kindly fill out the evaluation form afterwards, which can help improve programs like this in the future. Please also feel free to help yourselves to some snacks at the foyer. As one Philippine Heart Center, let us all work together for a VTE-free community. Once again, good morning and a good day to everyone.